Spinal manipulation is a precise, skilled intervention. In the next few minutes, we'll walk through safe setup and demonstration for cervical, thoracic, and lumbar regions, performed by a licensed chiropractor for educational purposes.
Hi, I'm Dr. Name, Chiropractor. Today we cover cervical, thoracic, and lumbar manipulation. Before any technique, we confirm indications, rule out contraindications, obtain consent, and ensure patient comfort.
Absolute contraindications include suspected fracture, dislocation, infection, malignancy, cauda equina, progressive neurologic deficit, and vascular emergencies. For the neck, screen for vertebral artery insufficiency, acute trauma, instability, or severe osteoporosis.
When in doubt, don't manipulate, consider alternatives and refer as needed.
We maintain privacy and professional draping at all times. Effective manipulation is specificity plus patient comfort. Position to slacken non-target tissues, localize the joint, pre-tension, reconfirm comfort, then deliver a minimal amplitude, high-velocity thrust along the facet plane when safe. Always reassess after each intervention.
We'll demonstrate a supine, segment-specific cervical technique for hypomobile segments. We avoid end range and stress comfort.
Confirm consent. Rescreen for dizziness, visual changes, or neurologic symptoms. Palpate to identify the restricted segment and preferred plane of motion. Position the patient comfortably. Cradle occiput. Encourage relaxed jaw and neutral breathing. Introduce gentle pre-tension in the facet plane. Avoid end-range rotation or extension. Deliver a precise minimal amplitude high-velocity thrust per your training, then return to neutral.
After cervical manipulation, reassess ROM, pain, and neurologic status, and document response. Thoracic joints often respond well. First, a prone posterior to anterior segmental technique.
With patient prone, identify the restricted segment through spring testing. Place a broad contact over the spinous transverse process and introduce gentle vertical pre-tension. On exhale, deliver a controlled, brief thrust per your training. Reassess mobility. Next, a supine mid-thoracic frontal hug with appropriate draping. Localize the target using a sternum or padded contact. Take up pre-tension by body drop. On exhale, deliver a quick small thrust and reassess.
For lumbar, we'll show a side posture technique emphasizing pelvic stabilization and neutral curve.
Confirm consent and screen for radicular signs or directional preference. Position the patient in side posture with the target stacked. Stabilize the pelvis and keep lumbar curve neutral. Avoid excessive twist. Establish a firm, specific contact at the intended segment and take up slack through hips and torso. Cue breathing. Deliver a crisp, short lever thrust along the facet plane per training, then immediately decompress.
Return to neutral, reassess motion, pain, and any neurologic signs. Document findings.
After manipulation, provide brief aftercare. Encourage gentle mobility, hydration, and note expected transient soreness. Integrate tailored exercise for durability, segmental control, thoracic mobility, hip hinge, and core endurance.
Manipulation is one tool in a patient-centered plan. When indicated, applied specifically, and combined with exercise and education, it can catalyze positive change.
For advanced coursework and safety updates, follow your regulatory guidelines and continuing education requirements.